Cool, you're welcome. Thanks for listening to an orthopod tell you about fluid considerations in the septic ICU patient. I hope it opens your eyes a little bit to how little we know. Yeah, this is usually as far as the orthopod's fluid considerations go. Usually just depends on the temperature of that water. Yeah, so as I said, I'm going to be talking about fluid considerations in the septic ICU patient specifically. So just to give some background on this topic, so the administration of IV fluids is one of the most common interventions in the ICU, in healthcare in general. And complications of sepsis has been shown to be one of the most common indications for resuscitative IV fluids in the ICU. The use of IV fluids is usually broadly classified into its proposed purpose. Sorry, that red is not projecting so nicely, but into resuscitative fluids, replacement fluids, and thereafter maintenance fluids. However, other resuscitative fluid models have been proposed, and they try to classify patients into specific phases of resus, i.e. the actual resuscitation, then optimization, stabilization, followed by de-resuscitation. The more evidence has led to the idea of fluid therapy as a drug, owing to the observed incidence of dose-related adverse effects and complications. So from this, we can gauge that not only too little fluids, but too much can actually do harm to patients. And many studies have attempted to answer the question of whether certain amounts of fluids and specific compositions of fluids provide benefits in specific situations. But despite widespread use in the critical care, fluids have only relatively recently become systematically evaluated in a range of clinical settings, including sepsis. Vast scrutiny regarding ad-lib fluid administration arose after evidence was produced showing that patients with large positive fluid balances had associated poor outcomes, specifically in the ICU. So the aim of my talk is basically to highlight considerations regarding fluid management in critically ill patients with sepsis and to reinforce some recommendations based on the available evidence. Just to talk about some physiology, so fluid administration aims to improve tissue perfusion by increasing intravascular volume. So if you remember from your second year textbook about the Frank-Starling principle, basically says that increasing your preload in a structurally normal heart Sorry, so I was saying, so basically the aim of fluid administration is to try and improve tissue perfusion by increasing the intravascular volume. So if you think back to the Frank-Starling principle from long ago, basically says that increasing the preload in a structurally normal heart increases or should increase your cardiac output, thereby increasing tissue oxygenation. However, the efficacy of administration depends on the baseline preload, as well as the duration of intravascular volume expansion following the fluid administration. So you basically need to keep the fluids that you're giving inside the vessel. Another factor influencing efficacy is that of the vascular semipermeable membrane, as well as the interplay between hydrostatic pressure, which is essentially the pressure exerted by the intravascular fluid onto the luminal wall, as well as the oncotic pressure, which is the osmotic pressure created by large charged molecules like proteins. So vascular permeability was initially thought to be regulated according to the Starling principle, which basically notes that filtration across the microvasculature was simply determined by the sum of opposing hydrostatic and oncotic forces. However, recently there's been a much greater appreciation of the role of what's called the endothelial glycocalyx, which is a group of glycoproteins and proteoglycans on the luminal side of the vessel, which play a role in regulation of vascular permeability. So they actually revised the Starling equation, and it's been expanded by identifying the glycocalyx as an independent structural determinant of the oncotic gradient. So that's a little selfie of the glycocalyx. So it's essentially a carbohydrate-rich gel layer lining the endothelium, and it's connected to the endothelium via these proteoglycans and glycoproteins, and essentially forms a network in which water-soluble molecules are incorporated. These are plasma and endothelium derived. And there's a dynamic equilibrium that's formed between the soluble components of this layer and the flowing blood. So the glycocalyx is essentially a dynamic biological layer, therefore assisting in the maintenance of vascular or intravascular homeostasis. And we've only recently become privy to this with more advanced biochemical and computational visualization of the glycocalyx. Its other functions are that it modulates leukoendothelial interactions, it actually assists with thrombus formation, and as mentioned, it's a regulator of vascular permeability. Why it's important for this topic is because during the initial onset of sepsis, the glycocalyx has actually been shown to be damaged, and this is what causes the sort of well-known increased capillary permeability in sepsis, leading to risks of tissue edema. So what is sepsis? Sepsis has been defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. As mentioned, the glycocalyx does get damaged in sepsis or severe trauma, which therefore increases transcapillary escape of albumin and subsequently water by the oncotic pressure gradient. This subsequently reduces the effective circulatory volume, and hence fluid administration is required in acute sepsis. However, because of the disrupted glycocalyx and large oncotic pressure gradient that's created, administered fluids are at high risk of escaping into the interstitial space. And hence there's a need for guided fluid therapy with evidence-based recommendations to prevent excessive fluid administration and subsequently fluid overload. Just to mention about septic shock, because septic shock is actually a subset of sepsis in which there's profound circulatory and cellular metabolic abnormalities. And why it's important that we identify septic shock versus sepsis alone is that there's a greater risk of mortality associated with it. And we can identify septic shock when we're required to use vasopressors to maintain a mean arterial pressure of more than or equal to 65 millimeters mercury despite an adequate fluid bolus. And the other thing that we can use to identify it is if there's an ongoing elevated lactate of more than 2 millimoles per liter despite adequate fluid resuscitation. We've touched on it, but what is the overall rationale for fluids in sepsis? So according to the Surviving Sepsis campaign, fluid therapy is one of the mainstays of treatment of septic patients. And the aim is to improve circulating volume, to improve cardiac output. And this is needed due to hypovolemia, which we do find in septic patients. However, it is quite multifactorial. Septic patients are often sick and therefore they have reduced oral intake. Have ongoing losses, especially from the respiratory and gastrointestinal tract, and as mentioned, with a damaged glycocalyx on the endothelial aspect of their vessels, they have extravasation from these leaky capillaries. There was a landmark trial that was done by Rivers et al. In 2001, which investigated the outcomes of patients with septic shock, and it showed a 16% mortality reduction in the population group which received resuscitation fluids as part of their management. So this sort of gave us the indication that fluids are actually associated with the increase with a beneficial mortality risk. So fluids have largely been adopted into usual practice, especially in the ICU. But is there an optimal strategy of fluid administration? So as mentioned, there is good evidence for fluid administration in sepsis, which has been shown to improve outcomes. But we also don't want to instigate the complications of fluid overload. And we also don't want the increased mortality burden associated with a positive fluid balance. This was actually evidenced by a prospective study, which included 173 patients in an ICU setting being treated with sepsis. And it showed a higher mean daily fluid intake in non-survivors versus survivors. The fluid output values were mostly similar, which showed that that there was a vast difference in the overall positive fluid balance. So positive fluid balance was independently shown to be associated with a higher mortality. It was quite a significant finding. So the optimal amount of fluid needed still remains quite unclear. There's also been much debate regarding the best type of fluid. There's been due to the idea of fluids being likened to drug therapy, owing to dose-related responses to different solutions. So different solutions essentially produce different physiological responses. And there's been many studies comparing crystalloids. There's been debates between whether balanced versus unbalanced crystalloids are beneficial, whether colloids are useful, and also combinations of the above. So what are the current recommendations amongst all this uncertainty? So according to the Surviving Sepsis campaign, the guidelines are actually updated in 2021. So for adults with sepsis or septic shock, they quite definitively said that crystalloids are recommended as the first line fluid. They then also expanded on this, saying balanced crystalloids are preferred over normal saline for resuscitation specifically. Normal saline does have a role in a select few patients, which I won't elaborate here. And there's also been a recommendation for the use of albumin in patients who receive large volumes of crystalloids versus crystalloid therapy alone. And studies have shown that there was no direct mortality benefit when albumin was used. However, less crystalloids were required in study populations that received albumin as well. Largely starches and gelatins in terms of colloid therapy has been or has fallen out of favor. They also speak a lot about vasopressors in adjunct therapy for fluids. I won't discuss this further. So just to talk about crystalloids, I mean, they've been given such high praise. So what's important about them is that they are cheap and they are readily available. And there is sufficient evidence on recommending the use of balanced crystalloids in sepsis over normal saline. There was a meta-analysis that showed that balanced crystalloids were associated with reduced mortality versus normal saline. There was also a trial called the SALT trial, which was a large randomized control study, which compared balanced crystalloids versus normal saline. And why this study was relevant is that they had quite a good representation of septic patients in the study population. However, their primary outcomes of overall mortality, new renal replacement therapy, as well as persistent renal dysfunction was actually similar, which was not their null hypothesis. Subsequently, there was another trial called the SMART trial, which was done in 2018, included a large number of patients who received normal saline or balanced crystalloids, and they actually alternated their therapy plans monthly. The balanced solutions were associated with a reduced 30-day mortality in this group. However, there were some pitfalls in that it was a single center population group. There wasn't any blinding done, and they actually only administered moderate amount of fluid. So it didn't give a sort of indication regarding the risks of excessive fluid administration in terms of balanced crystalloids versus normal saline. Most of the concern regarding normal saline pertains to the complications of hyperchloremia and also the associated metabolic acidosis with the excess chloride administration, concern about renal vasoconstriction, as well as increased cytokine secretion, and concern about acute kidney injury. Therefore, the guidelines have erred on the side of recommending balanced crystalloids. What exactly are balanced crystalloids quickly? So they're basically more physiological solutions in that they contain sodium, potassium, and chloride, a content that's similar to the extracellular fluid. When given intravenously, they do have a less effect on the acid-base balance of the patient. Examples that we're familiar with include Ringer's lactate and plasmolite. Just as mentioned about albumin, as we know, albumin is quite expensive. However, there is theoretical knowledge that it maintains the oncotic pressure and then, or hence expands the intravascular volume. However, there's no evidence supporting its routine use. There was a Cochrane review which included over 12,000 patients, which compared the use of albumin alone versus crystalloids. And there was actually no difference in overall 30 or 90-day mortality, which doesn't support the routine use when crystalloids are available. Another meta-analysis also included critically ill patients, actually showed a lower static filling pressures and mean arterial pressures with crystalloids, but there was no difference in overall mortality. And then the Albios trial, which is actually the largest clinical trial done in sepsis, compared a combination of albumin and crystalloids. The crystalloids alone, again, no difference in mortality was shown. However, albumin was or is still recommended in patients who've received large volumes of crystalloids. And this is due to the evidence found that higher mean arterial pressures and higher static filling pressures are found when albumin is used as an adjunct to crystalloids, and therefore these patients have a net or lower net fluid balance. So although there's no evidence for improved mortality risk in patients who receive albumin alone or in combination with crystalloids, there is a proposed benefit in lowering complications associated with fluid overload and a net positive fluid balance. So there's sort of clear-ish guidelines on which fluids to give. However, how much fluids do we give? So a review of the available literature shows that the question of how much fluid is optimal in these patients is actually quite challenging. The answer remains quite unclear owing to the paucity of strong evidence which could guide the development of protocols. Studies have attempted to identify this value by comparing standard fluid therapy versus what a lot of researchers called early goal-directed therapy, which is essentially including the measurement of the hemodynamic status of the patient and circulating volume, using various direct and surrogate markers of overall circulatory volume, i.e. Central venous pressure, venous O2 saturation, as well as lactate measurements. And the use of a targeted CVP value of 8 to 12 millimeters mercury was actually advised by the Surviving Sepsis Campaign guidelines up until 2012, when subsequently 3 randomized controlled trials, specifically the RISE, PROCESS, and PROMISE trials, showed no mortality benefit with applying early goal-directed therapy. So they've subsequently removed these guidelines or these recommendations from the Surviving Sepsis guidelines, and they don't actually advise a specific target CVP and venous oxygen saturation levels. So the current recommendations from the Surviving Sepsis Campaign, again, these are relatively recent recommendations from 2021. So they recommend that patients are loaded with 30 moles per kilogram of balanced crystalloids within 3 hours. Further fluid management should actually be guided by dynamic parameters and clinical examination, such as simple things such as capillary refill time, but they still stuck to advising serial lactate measurements. So these dynamic parameters include echocardiography, which has actually become quite common in intensive care units, using assessing the pulse pressure variation of patients or other non-invasive cardiac output monitoring while using passive leg raising or fluid bolus challenge to see if patients are fluid responsive. It's important to note that they documented this recommendation as a weak recommendation owing to the lack of strong evidence in this regard. So they actually didn't just thumbsuck this value. It was an observational study done in 2016 of about 1,800 patients with septic shock. that they used the amount of 30 moles per kilogram as a resuscitation bolus, and it was associated with a reduction in risk-adjusted mortality. And then a further retrospective study in the United States later on used that value and showed that failure to achieve a level of 30 moles per kilogram IV fluids in the first 3 hours was associated with an increased mortality risk. And then another single center ICU-based study showed that lower mortality rate was actually associated if you could complete that bolus in a faster amount of time. However, this wasn't backed up by further larger multi-center trials. So amongst all this uncertainty, two further strategies have been proposed for ongoing therapy, namely liberal administration of fluids versus restrictive administration of fluids. This has actually been quite a topical discussion as of late. So there still remains no clear definition as to which amounts these strategies actually entail. Someone went out on a limb, Self et al. Did a trial in 2018 and actually noted the restrictive fluid balance being what was proposed at 30 moles per kilogram versus a liberal fluid protocol being 50 to 75 moles per kilogram. But is there actually mortality benefit between these two strategies? So recently there's been a lot of evidence in this regard. So literature search of multiple databases yielded 4 studies which could potentially answer this question. So there were 2 randomized controlled trials that were identified, as well as 2 systematic reviews. So this is the first one. It was on Mayoff et al. In 2022, so quite recent. And this was a randomized controlled trial where they assigned 770 patients to the restrictive strategy and 784 to the standard or liberal strategy, and showed that the mortality at 90 days was mostly similar, 42.3% and 42.1% respectively. And it was actually quite a good study design. There was good randomization. Sample groups contained patients with similar pre-resus prognostic factors, for instance, patients or equivalent patients with metastatic malignancy and hematological cancers as well. And they also used the most recent criteria for diagnosing sepsis. And there was also quite good exclusion criteria. However, there was the study was quite rife with pitfalls in that. Well, for one, it was conducted purely in Europe, which made generalizability quite limited for our setting. Another issue was that patients were screened and selected only in the ICU, which caused a lot of sampling bias owing to a diversity of presenting areas. In that patients were admitted to the ICU from the emergency unit, from the ward, from theatre, which produced quite a lot of heterogeneity. There was also quite an old median age in the sample group of about 70 years. And a significant number of patients had hematological and metastatic cancer, as I mentioned. And there was actually no blinding done for the patients or the clinicians, which could definitely have influenced treatment decisions. Another factor was that most of the infections were of GIT origin, in contrast to respiratory, which the majority of sepsis trials actually, which is actually respiratory illnesses are mostly included in the majority of sepsis trials. So the second randomized control trial was actually more recent, in 2013. So a similar amount of patients were included, 782 in the restrictive group and 781 in the liberal group. And again, 90-day mortality was mostly the same. Again, it was quite a good study design. There was good randomization. There was clear goal or outcomes. The majority of the patients, compared to the previous study, were actually recruited from the emergency center. Therefore, this group or population group was much less heterogeneous at the time of fluid initiation. However, again, multiple pitfalls. Study was done in the States, therefore limiting the generalizability in our setting. Also, predominantly white patients were included, which again reduced generalizability for us. There was also issues with recruitment in that some days the recruiter wasn't available, and therefore there was a lot of patients missed, which could have amounted for some bias. And again, no blinding could be done in this trial. Another thing to consider was that they actually initiated vasopressors quite early in the restricted group, which could have had a distinct influence on the results. So this was the one of the systematic reviews done. This was done in 2022. It actually contained 8 randomized controlled trials and total number of about 2,300 patients. And again, the mortality showed that there was a 37% mortality with the restrictive versus a 40% mortality in standard fluid therapy, therefore not showing much difference again. And this was the last systematic review found, which included 9 randomized controlled trials. And again, no statistically significant difference between the lower and higher fluid volumes in all-cause mortality. So there were some pitfalls in both of the systematic reviews, in that there was overall there was a lot of randomized controlled trials included, but none of those actually included a large study population. I think the highest study population was 151 patients. And also of note was significant clinical heterogeneity. For instance, the type of patients, the type of sepsis that was being dealt with, as well as when fluids were initiated. Therefore, although these study designs were actually quite good, they produced quite weak overall data. So just to end off with a discussion about this, the fluids are a universal management strategy and are initiated in many clinical settings. In most practice, there's no protocols that guide fluid management, and often we see that it's guided by clinician experience as well as their preference, the clinical response to treatment, as well as the patient-specific presentation. And anecdotal evidence shows that most people in our setting don't actually adhere to the surviving sepsis guidelines of an initial 30 ml per kilogram bolus resuscitation fluid. And most people actually tend to prefer a restrictive approach with early initiation of vasopressors. However, this is going against the fact that there's limited evidence in this regard. However, a lot of people are afraid of the potential for fluid overload and associated increased mortality risk with patients having a positive fluid balance. The pitfalls of the studies, which theoretically should have yielded quite high quality evidence, shows that it's actually quite difficult to conduct fluid therapy trials, and this being largely due to the heterogeneity of protocols and sample groups available in these clinical trials. And this results in the evidence not supporting the use of either a restrictive or liberal fluid strategy in adult septic patients. What do we know, and what can we actually use to guide our management? So what we do know is that fluids are a mainstay of treatment in septic patients. There is a reduction in mortality when fluids are used in resuscitation of septic patients. It's also important to understand the pathophysiology of why septic patients do require fluids. Again, important to consider the damaged endothelial glycocalyx, and increased vascular permeability to understand where our fluids are going when we administer them. What we also know is that balanced crystalloids are preferred. There's been extensive evidence showing that they are associated with a reduction in mortality versus unbalanced crystalloids like normal saline. Albumin has also been shown to be useful in patients, especially in septic patients who are receiving large amounts of crystalloids. A 30 ml per kilogram bolus in the resuscitative phase is a safe starting point. And ongoing therapy should actually be guided by dynamic clinical parameters more than other surrogates like the central venous pressure, venous O2 saturation, and the mean arterial pressure. There's no conclusive evidence to recommend a restrictive approach to fluids over a standard or local approach in terms of mortality. But you can also look at this in another light. Patients who receive a restrictive fluid strategy and often earlier vasopressors do not have a worse mortality, and this may forego further complications such as fluid overload and the positive fluid balance. So often a restrictive fluid approach with earlier vasopressors would be preferable.